Hi, folks. Good morning and good afternoon from where you're joining us from, depending on. Um, Having a little bit of technical audio that we're trying to work through. So if you don't mind, if you can hear me, just give a react, give like a little thumbs up just to confirm. Ah, that is good. That is good. So I love seeing all the thumbs up. I like some of those hearts too. That is great. So apparently, the only person who can't hear me right now is Jeanie Heck. So, I mean, that's okay. We're going to work through that. But Jeanie, you're going to have to advance these slides. So, what I'll say right now is that the only piece that I had was that our CEU evaluation will take place at the end. I will drop that evaluation link in the chat. And I will also be sure to put that in the Q&A, and we will send an email evaluation, the evaluation through email. So with that said, I'd like to welcome you to Coding Coven. We had an overwhelming response here. I think we had 1,300 folks over that registered. So it's so nice to join you today for this. And without further ado, I think I'll use my hand signals here to pass it over to Jeanie to advance the slide. There we go. That'll work. And thank you guys for those thumbs up.
Okay. Okay, perfect. Thanks. Hi, everyone. My name is Jeanie Heck, and it is a pleasure to be speaking with you all today. It is really fun to do these webinars, and of course, when they're free, it's even better. For those of you that know me, a big welcome to you all. And for those of you who are meeting me for the first time, really, really nice to meet you. This is all possible at E4 Health. I'm an education consultant here. If you haven't heard me before, perhaps maybe you've heard my colleague, Kim Felix. She's the Vice President of Education here, and a big shout out to her as well. I've been doing this for a really long time. E&M is absolutely one of my favorite things to talk about. So without any other further ado, let's jump right in, and hopefully you'll like what we have to share today with you. I do have a favor though. If you could put some of your comments in the chat, that would be so helpful. We make this possible because of you. And I have a little tricks and treats in here because Halloween is a couple days away. So we just want to make sure we're having a little bit of fun. We can be serious and we can be fun at the same time. So I'm going to turn off my camera and get this thing going. Thanks, everyone. All right, I know Mike already talked to you about our education team and about E4 Health. We are a great place to work certified as of last year. A little bit about me. I've been in this field, like I said, for over 30 years. I absolutely love E&M. I come from the private practice world, so I am absolutely a provider advocate. And to those of you who have worked with me in the past, you know that for sure. That doesn't mean that I don't love working with coders and auditors. We are one for all and all for one, as I like to say. Our education and training disclaimer. The information and opinions presented here are based on the experience, training, and interpretation of the author. Although the information has been researched and reviewed for accuracy, the instructor does not accept any responsibility or liability with regard to errors, omissions, misuse, or misinterpretation. This information is intended as a guide. It should be not considered a legal consulting opinion or advice, and it's proprietary and should not be copied or distributed by anyone other than E4 Health. But here we go, everyone. Couldn't start out any kind of Halloween webinar without a little Thriller, the most iconic Halloween song of all time. Here's our agenda, and I know that you received a little bit of a sneak peek when you signed up. So we're going to talk about services reported separately, meaning what about reporting that E&M code with a wellness or preventive code? And also reporting that E&M code with a procedure code. Of course, we're then going to have to talk about modifier 25 if we're talking about this concept of separately identifiable. And everybody's new favorite, I think, G2211. So I definitely have some thoughts and guidance on that. And then we're going to talk a little bit about combination codes, vaccine, and then give you some final thoughts. So let's start right out with a bang. This is probably one of the hottest topics that I am asked about as an education consultant, and I love talking about this. So what are we going to talk about when we talk about services reported separately? Well, the two biggies, right? For reporting that preventive or wellness visit with a problem or sick visit, and also providing a E&M code when there's an in-office procedure that's also taken place at the same time. So what I want to start out with, and for those of you that know me, you know I am extremely passionate about only and always using authoritative guidance. That is super important. I will tell you, as a high-level auditor and having worked for CMS and entering my 10th year doing that, we only take authoritative guidance. So absolutely make sure that's what you're using as well. So on the AMA's website, there's one of my favorite spots is called Debunking the Myth. And they have a lot of different topics. The one topic that I want to bring to your attention today is coding and billing for preventive and problem-focused E&M services in the same encounter. So they go on to say, hey, is this possible? And the answer is, of course it's possible, but you can see what I have highlighted in yellow here. The significance of the problem addressed and the amount of time and medical decision-making required help determine how the services are most appropriately billed. So let's dive a little bit deeper into this. And you can see the portion of the visit must be medically necessary and reasonable to treat the patient's illness. And I want you to pay attention to what I have highlighted in blue here about that additional E&M code. We're not going to pick up that extra code if the problem, even if it is slightly addressed, and I'll get into that more later, if it's insignificant or trivial. But I have to tell you, as you know, I do a lot of provider education, both one-on-one and or group or small group. I will tell you that I have learned most recently, that some healthcare organizations, do not like to also bill that extra E&M visit because there's going to be that out of pocket for the patient. But honestly, that's kind of not fair. If you're billing and seeing a patient for a wellness visit, and also there is something significantly separately identifiable, then they are going to be responsible for that copay for that problem-oriented visit. Everybody knows about the preventive wellness visit being a zero copay. And so I think the notion is that a lot of patients like to come in, and while they're there, They just like to start talking about everything else. And I know sometimes a provider might be a little hesitant to pick up that extra code. Just to give you a little sneak peek, there's 29 topics in debunking the myth on the AMA's website. So this is just to give you a little sneak peek of what you can find. But if you don't subscribe to the AMA, you're really missing out. So make sure that you look at this, and especially look over some of these topics that you're going to find here. All right, let's go a little bit deeper with the E&M code and a wellness preventive code. Of course, we have to start out by looking at our preventive medicine services guidelines. So the 3 bullets that you're looking at on this particular slide all come from the CPT manual itself. Also, if you've heard me speak in the past, then you've probably heard me talk about CPT's Quick Ref app. You can see it here on this slide. I purposely put a copy of the CPT 2025 with that CPT Quick Ref app here. It's about $40 extra when you're going to purchase your CPT manual, but get this, CPT Assistant is available if you purchase it as a bundle with the Quick Ref app. You would download an app on your phone. So for $40, if you're not able to get CPT Assistant, it's really, really worth that extra $40. All right, back to our preventive medicine services guidelines. So they go on to say that if the problem or abnormality is significant enough, and here's the key takeaway, to require additional work to perform the key components of a problem-oriented evaluation and management service. And then, of course, we attach modifier 25 to the office/outpatient code. But let's look at that very last part. The comprehensive nature of the preventive medicine service codes reflect that age and gender appropriate history and exam. But what our guidelines are saying to us in the preventive medicine section is this is not synchronous with the type of comprehensive exam required in our E&M codes. So automatically, me as a coder and or auditor is thinking to myself, okay, these clearly have to be separated and separate. So let's talk about that concept of separately identifiable. So we already know, because our guidelines tell us, that if the problem or the abnormality is trivial and it doesn't require extra work, we should not be picking up that extra code for that office visit. So in other words, if there's some type of observation that is made at the same time as the preventive visit, I would not pick up that extra code. But let's go to the flip side of this, and let's talk about some case scenarios where we would pick up that code. Mrs. Jones comes in for her preventive visit. The provider also looks at a rash and prescribes a topical treatment. Within the documentation, we have an assessment and HPI. Now, I'm not talking about the same documentation that you would use for a wellness visit. Remember, our preventive medicine guidelines tell us that these are not to be kept together. They have to be separate. That is a huge takeaway. And I'm a person who likes to read in between the lines because I try to make it as black and white as possible. And that's something that I think a lot of people may overlook. Let's look at the second case scenario. Patient's blood pressure is elevated. Again, there's documentation assessing the condition and medication is prescribed. So once again, it's all about the documentation. And you'll hear me say often, I feel like I'm a coach when I'm talking to providers. And you as a medical coder or auditor, that is exactly the way I think it's best for you to talk to your providers as well. refrain from the you need to do this, and make it more of a we, because they didn't sign up for this when they went to medical school. So they need all the help they can get. All right, here is a situation where I would only code that preventive visit. Let's look at the patient status. Good overall health, no chronic problems. That's a wellness code only. How about this scenario? 1 or 2 chronic stable conditions, but I want you to pay particular attention to what I have highlighted in yellow because it's that important. These 2 chronic stable conditions, which honestly, often the stable conditions are addressed within the preventive note. However, if you're only including, or if your providers are only including a very limited description, the exam is normal, there's no change in treatment, that doesn't necessarily mean that we're going to pick up that extra code. Now, again, I'm going back to that same notion. It all boils down to the documentation. Even if prescriptions are refilled or labs are ordered, if there's no management or evaluation or assessment of those chronic conditions on the day of the visit, I would not pick up that additional code. So when I talk about limited description, I'm talking about there's hardly any assessment of that. So let's look at the last bulleted item that I have on this slide to think of it in a different way. So let's just pretend the patient is coming into the office, but honestly, they wouldn't be there if it wasn't for just that preventive wellness visit. Let's look at some scenarios where I would pick up an additional office visit code. And the example that I'm using here is a level 3 established patient, an acute uncomplicated illness. So the patient comes in for their preventive visit. They're also complaining of left shoulder pain. Now, this is my honest to gosh biggest takeaway, and what I would tell you to absolutely coach your providers on, so that there's no misinterpretation from an auditor point of view. Always be sure to document a separate HPI for that illness or issue that you're also discussing in addition to that preventive visit. It's huge. So that also means that you're going to have documented, or you should see documented, some kind of medically appropriate exam for that particular situation. Maybe you're going to schedule tests. Maybe you're going to prescribe a medication. And of course, when I say maybe, I'm obviously referring to the provider. Remember, here's the caution again, refilling existing prescriptions for a known chronic stable illness. Again, that by itself, to a lot of auditors, and I'm talking high level, MACs and CMS, will not automatically equate to billing that additional code. Let's talk about a preventive visit and a level 4. So I'm going to give you a lot of different scenarios here. An undiagnosed new problem could be an exacerbation of a chronic illness or multiple stable problems, because I'm sure some of you are thinking, oh my gosh, what do you mean we can't send in that extra visit if they are addressing stable problems as well? I'm talking about chronic problems. Just make sure that there's a little bit more documentation within that assessment of those chronic conditions. So what should our documentation show? I'm going to start out again with what I discussed on the previous slide. Me, as an auditor, I'm looking for the HPI for those issues. So a lot of times, when a patient comes in, you have to fill out the chief complaint or the reason for the visit, and it might just say preventive, right? That's fine. But then when you get into that problem-oriented portion of the visit, I want to see an HPI for that. What does that mean? That means I want to know the onset, if it's an undiagnosed new problem, and maybe what that treatment plan is. If it's an exacerbated chronic illness, or if there's multiple stable problems. And you can see in my little yellow rectangle here with multiple stable problems, what am I talking about? I'm talking about there is a review of the treatment plan. There's complex multiple medications. Maybe you're referring that particular patient to a consultant. Those are the types of stable problems I'm talking about. If it's an exacerbated chronic illness, maybe there's a new abnormal exam finding, or perhaps maybe the patient's condition deteriorated from the prior visit. Again, you know, with our new guidelines, we need that medically appropriate exam for the illness and problem. I'm going to go back to repeating myself again about this. Remember when I showed you the guidelines for the preventive visits, and it said that that exam portion that you would do that is age or gender related is not the same for this particular scenario. That's what you need to pay attention for. Maybe you're scheduling tests, maybe there's changes to the treatment, and if it's an acute problem, maybe in the documentation it says that they're going to follow up in a couple of weeks. There is a really wonderful CPT assistant article from March of 2023. If you're looking for it, it's called Modifier 25 Reporting. The reason why I want to bring this to your attention is because they have a really great example of a preventive medicine service performed on the same date as the pediatric visit. Now, I'm not going to read through this whole thing, but I want you to understand why I'm saying what I'm saying about using that extra code when someone's coming in for a preventive visit. When I read this CPT assistant, what I hone in on is comprehensive, that what I have highlighted in blue, it's saying that there's a comprehensive system review, right? That's huge. Don't miss out on that. Also, look, the physician asked for additional history of the acute concern, right? And then the mother goes on to talk about that. In summary, in the red triangle or red rectangle, the physician performed the key components of a problem-oriented E&M service, which included a medically appropriate history and exam, and it was significant beyond the services of the preventive medicine visit. So to sum this up, if it's existing problems, make sure that we see monitoring, evaluation, and an assessment. In other words, it's a significant review and it's not just a few words. If you were to take away anything that I've just said, honestly, the most important takeaway is documentation of that HPI, and that medically appropriate exam is equally as important. And I'm going to repeat myself once again, it's because the guidelines tell us they're separating those. So from an auditing standpoint, I always say, and sometimes I am not met with a lot of happy smiles for this, but 2 progress notes would really, really make a difference, because then we have our wellness visit and we have our problem-oriented visit. That would decrease the likelihood of denial. I know that some providers are going to absolutely say, no way, there's no way I'm doing this, but just know that they must be significant and separately identifiable using that HPI and exam. All right, how about reporting an E&M code with the procedure code? Let's talk about in-office procedures in general. We come back to that same notion of significantly and separately identifiable. Why? Because all procedures typically include pre and post work. So what am I talking about when I talk about pre and post work? This is what I'm talking about. This is included when there's an in-office procedure going on. And I think a lot of times there's a disconnect with the providers that maybe they're thinking that the items that you're looking at on the slide in front of you is going to count towards that E&M visit, and they don't. The other thing that I want to bring to your attention from an auditing point of view, and this just makes common sense. Let's talk about new patients versus established patients. So if the patient is new to that provider, then they don't know that particular patient. So the baseline history and exam is typically going to be a lot more in depth as opposed to an established patient. So am I saying that if it's an established patient, you can't also get that E&M code? No. But what I am saying is that it's more common with new patients. But I don't want you to think that I'm saying that you can't do it, because you can. I'm just bringing this to your attention because from an auditing point of view, I see this quite a bit. That same CPT assistant also has a really, really great coding scenario. It's an established patient comes in with a growing lesion on the nose. However, the patient also talks about growths on the back, right? So the patient is reassured that those lesions are okay. The provider prescribes a medication and the treatment plan is discussed, meaning it's documented. So those are significant and separately identifiable problems. So this would absolutely be a situation where you would definitely pick up that office visit code in addition to the procedure code. Again, make sure your documentation clearly separates the E&M portion of the note from the procedure portion of the note when you're coding and or auditing. A question you might want to ask yourself or talk to your providers about is the extra work during that particular visit beyond that usual pre-op and post-op. Let's look at modifier 25 before we jump on to our next section. Modifier 25 review. And don't forget about Appendix A in the CPT manual. That's where we find definitions of all of our modifiers. We know modifier 25 is only used with E&M codes. We're going to put it on the E&M service, and it represents to the payer, hey, something significant and separately identifiable is going on here. So please pay attention to this. And again, we want to make sure that it's properly documented in the medical record. G2211. As you know, it's an add-on code, right? For all of my Profee coders out there today, that means that we would not add a modifier to that particular code. So it's a new code, right? So whenever there's a new code, hands down, you better expect it's going to be audited. Of course, it's going to be audited. So the definition of G2211 is longitudinal, ongoing relationship. But CMS has made it clear that there's no definition for longitudinal. But we know this is an ongoing relationship. This is not restricted to any specialty, but I think when it first came out, there was a lot of focus on primary care because we know primary care providers really are what we have known as the gatekeepers for so many years. Here's the criteria that you want to think about when you're looking at a progress note that has G2211 attached or when you're giving guidance to your providers. Do you have or intend to have a long-term ongoing relationship? Or, and it's a big or, is there a patient, one patient's serious condition, and you are the caregiver? From a documentation standpoint, they're going to want to see consistency and that same diagnosis repeated. So if you were to be audited for G2211, they're going to want to see past progress notes for sure, which can sometimes be really challenging for you if you do auditing. Because if you're not privy to all of those previous visits, it's a judgment call, right? But our documentation should demonstrate clear direction, complexity, and a care plan for continuity. As an educator, my job is to stay on top of the newest rules, guidelines, etc. I will tell you, I'm a frequent flyer of all of the MACs, the AMA, as you know, because it's just what I do. In July, in the summer of this year, the Evaluation and Management Services, the MLN booklet, was updated. And then, I don't know if anyone noticed, it went down. Then it came back live and it was updated again on September the 30th. The reason why I'm talking about this today is because one of the new additions, and this was new as of September 30th, it also was in the July one before they took that down, but I have it right here and it has to do with G2211. Now you can add that for your office visits, whether it's a new patient or established, your annual wellness visit, vaccine administrations, and any Part B preventive service. The proposed rule for 2026, they're saying, hey, let's extend this to home and residence-based services. I have a feeling that they will make that permanent, but we will find out soon enough. Let's look at one of the MACs, and I'm using NGS as our example. And it talks about the difference between that single serious condition and or a complex condition. And one of the examples that they talk about is HIV or sickle cell. So that would give you an example. And of course, there's many other single serious conditions that a patient could have. This is just some of the ones that they talk about. And of course, you are the continuing focal point. So I will tell you, as for someone like myself who has been doing this for over 30 years and it's a new code, how am I coaching my providers to make sure that this is not going to be challenged? Or if it is challenged, hey, you've got great documentation. Let's talk about documentation from NGS's perspective. Then I'm going to give you some examples of what I would like to see included. NGS goes on to say, we would expect that information is absolutely included in the medical record or the claims history. That's why I said a couple slides ago, if you are to be audited, they're absolutely going to look for past visits to make sure, oh yeah, there's that diagnosis again, I see it. And you can see the non-facility participating rate, reimbursement, is $15 and some change. So you wouldn't want to lose out on this. From talking to healthcare organizations, I have largely found that CMS is pretty much reimbursing this. As far as private payers go, it's a little bit of yes and a little bit of no, but that wouldn't deter me from sending through that code if the documentation justifies it. So now we looked at some of the MACs. Let's look at some of what I think would help. So when I coach a provider, this is what I would say. Remember that debunking the myth slide that I showed you in the beginning of the presentation. One of the 29 myths has to do with templates. It is absolutely okay to use smart phrases or templates within the EMR as long as it is tweaked and edited per your individual patient. Now, also with regard to these smart phrases, because you're looking at 3 of what I think are pretty gosh darn good ones, but I want you to pay attention to what I have highlighted in this slide, and that is, even though we have this terrific templated response that, in my opinion, will really help support G2211, I still want to see a thorough assessment of that particular condition or conditions documented by the provider. Why do I have follow-up on this slide? I'm going to give you another trick that I would coach my providers with. So let's just think about this logically. If this code is showing that you have this long-term relationship, then I bet you're probably going to see that patient again, I don't know, maybe in 3 months, maybe in 6 months. So my suggestion about that is be sure to document in your note, follow up in 3 months, return to the office in 4 months, whatever your providers generally use. But that also, that one sentence alone about the follow-up also reinforces the fact that, yes, I do have this ongoing relationship with this particular patient for this particular condition. Combination codes, it definitely deserves a Phantom of the Opera's entrance, because I can't believe still how often we don't take advantage of them. And with version 28 of our risk adjustment coming around, we need to pay attention. Let's start out with diabetes, and I'm talking about the manifestations and/or complications. Many manifestations of diabetes, and you can see we have a lot, because this snippet is right from a coding manual. Our guidelines tell us that when a patient has diabetes and any of the conditions that are listed on the slide in front of you, we can automatically link them without the provider telling us that within the documentation. Now, if the provider says, hey, these two are not related, then of course we're not going to. But I will tell you, there's no way I'm memorizing this entire list. So what I always recommend to my coders and auditors is get something similar to this. Open up your coding manual, make this own little tip sheet, cheat sheet, whatever you want to call it, so that you know these are automatic links, even if the provider doesn't do it, him or herself. However, let's talk about the NECs. To just reinforce what I talked about regarding the with guideline, if you are wanting to look at that exact guideline, you're going to go to 1A15 within the ICD-10 guidelines. And that's where we talk about that relationship is presumed. But I want to bring to your attention a coding clinic from 2018 that specifically addressed those conditions, followed by the abbreviation NEC for not elsewhere classified. I have every single one highlighted in blue. And if you were making a tip sheet, I would tell you to do the same so that they absolutely jump out at you. The coding clinic goes on to say, if the condition has that NEC behind it, we are not going to connect them unless we have a more specific diagnosis. So the example I'm using here is documentation states diabetes type 2, stable, and glaucoma. Ophthalmic complication, because obviously glaucoma is an ophthalmic complication, but if you look up here, that's an NEC, because we don't have glaucoma in our list. That means we don't link these, we have to code them separate. Let's talk about the another obvious diagnoses, set of diagnoses that automatically link because of the guidelines: hypertension and heart disease, hypertension, diabetes, and chronic kidney disease, hypertension, heart disease, and chronic kidney disease, and hypertension and chronic kidney disease. And you can see I've listed all of the coding guideline sections for all of these different examples. And it really, really matters, because a lot of these are HCCs if you use the proper code. And I also realize that in our world, a lot of providers are doing their own coding. So if you're helping them because maybe you only review, say, 1 out of every 10 progress notes, make them a tip sheet. Give them the most common coding scenarios with the codes so that they don't miss out on this as far as a risk adjustment diagnosis is concerned. Let's talk about vaccines. Another one where a lot of times when I go in and do an assessment for a hospital system, and I'll say, let's talk about vaccines, because there's often so many vaccines where they're missing the administration codes. So let's talk about the basics. We know within that medicine section of our CPT manual, we're going to find the codes, right? We're going to find the codes for the vaccine and or toxoid. There's two basic types of administration codes. One is with quote unquote counseling. However, and it's a big however, you can only use this code if the patient is 18 and younger. And then we have our without counseling codes. So on the bottom of this slide, you'll see when we have our face-to-face counseling, I want to see documentation of that face-to-face counseling. And those codes, again, are used through 18. So in other words, if the patient is 18, we're still able to use them. And we're going to talk about these toxoid components on the next slide in a little greater depth. Let's go over to the other side. When there's no counseling, you still have to use an administration code. And I don't want you to lose out on that because it's a lot of reimbursement. And if there's more than one vaccine given and there's no counseling, then you're going to have more than one administration code. So in other words, you give a vaccine, you have an administration code. This is something that is often confused also. Now, let's talk about vaccine components. Within the CPT manual itself, it says combination vaccines are those vaccines that contain multiple vaccine components. So I'm also a big fan of the Coder's Desk reference. So I have a snippet of both of these for the 90471, right? And for our counseling codes, because there's a difference with regard to how we treat the vaccine components. And honestly, the best way to explain it is by giving you some examples. This is an example with provider counseling because the other one is pretty much more straightforward. So we have a 15-month-old established patient seen for a well child visit. The doc administers both a DTaP and MMRV. Now remember, we have to have documentation that there's counseling provided. Now let's go back to that notion of the antigen and the components. So we have our preventive medicine visit at the top, 99392, right? Ages 1 through 4. We're using our modifier 25. We have our code 90700 for the vaccine itself, but then this is the way we use our extra codes for each individual component. We have 90460 for the diphtheria part. We have 90461 for the tetanus component, and we have 90461 for the acellular pertussis. Now remember, that baby also had an MMRV. Same thing. We have our 90460 for that first measles component. We also, of course, have the MMR vaccine code itself, 90710, but then it's MMRV. One code for measles component, one code for the mumps component, which is 90461, one code for the rubella component, and one for the varicella component. So don't forget to take advantage of all of these component codes. Like I said, you'd be surprised how often it happens that they're missed and maybe you only send in the 90460 when there's reimbursement being left on the table. I'm repeating myself one more time. This is only applies when there's counseling, and counseling only applies if the patient is 18 or younger and it's documented within that progress note. And of course, don't forget our Z23 code for encounter for immunization. Let's look at an example with no counseling. So I'm saying that this patient is 19 years old. So we know they're over 18, and it doesn't, you can use these codes that we're looking at right now in this example if the patient is 18 or less. if there's no counseling. 19-year-old is seen with a lump on her scalp. The provider determines it's a sebaceous cyst, and the patient is referred to a dermatology clinic. But the